Thank you so much, sir, and all the chairpersons. A big thanks to the BDCon organizing family for making me a part of this beautiful conference. I share my roots in the Eastern Coalfield area, so it's always fond memories coming back to this city. So moving on from the mesmerizing oration by Thomas, sir, my job is perhaps the opposite. Now we are talking about obesity, specifically managing childhood obesity. And when we talk of childhood obesity, we have a huge spectrum. I will be primarily restricting my presentation to exogenous obesity because syndromic obesity was already discussed in detail yesterday by Dr. Sunetra. So if you have to talk of an obese child, I think it would be incomplete if you don't look at the parents or the adults at large. So this is the data which we published from our center in 2019, so it's almost a 6-year-old data, where 5,300 odd patients who had walked into our center, whatever cause, maybe hypothyroid, diabetic, for anything and everything, we just meticulously record the anthropometry. What we found in West Delhi was that having a normal BMI are actually an endangered species. Hardly 13.7% people had normal BMI. BMI means a BMI between 18.5 to 23 kilograms per meter square. Almost everybody was overweight and obese. In fact, if you see a normal BMI people, in Delhi it is taken that you might be sick, you might be having some underlying illness. So people start questioning you. Obesity has been so normalized. Why it is important to see is perhaps because whenever we get to see obese child, at least I have never seen an obese child who doesn't have an obese parents. So if a childhood obesity comes to us, we make the child sit outside and talk to the parents. We tell them, unless you improve your diet and lifestyle, nothing great is going to happen. And it is the mother's satiety which decides how much the child ends up eating. Kids will say very fast, I am full, I don't want to eat. But unless the mother or the father is satisfied, they'll keep on feeding the child. And once you do it for months to years, the satiety point goes up, and that leads to the vicious propagation of obesity. So when we talk of childhood obesity, this is a systematic review which is under review for publication. We have to realize a childhood obesity has a history going back 2 generations, and the effects can be seen even ahead 2 generations. Here we try to look at we have low birth weight babies and macrosomic babies. So we try to look at what if the mothers were low birth weight or overweight when they were born, or fathers were low birth weight or overweight. Will it have an impact on their kids' birth 20, 30, 40 years down the lane? So surprisingly, we found that there are a lot of studies evaluating this. We analyzed data from 14 odd studies having more than 3,20,000 patients. And if you see here, adjusting for all the other factors, if the mother was born of low birth weight, she has nearly 2 times the chance of having a baby with low birth weight 30 years down the lane. And that would be a higher risk for also neonatal small for gestational age. Of course, the risk will be large for gestational age will be lower. On the other hand, mother who was born macrosomic would have 2.5 times of having a macrosomic baby 2 to 3 decades down the lane. So if a lady has GDM poorly controlled, she has a macrosomic child, we would see the effects even 2 generations down the lane. Is it even more? We don't even know. And what is interesting, we found that in terms of birth weights of parents to the progeny, the maternal link was stronger as compared to paternal. But suddenly we found an unexpected thing. Paternal but not maternal low birth weight was a better predictor of metabolic syndrome and diabetes in their future generation. So some genomic imprinting is coming into play, we really don't know. So I think we must realize when we talk of childhood obesity, we should look at the whole picture 2 generations back, and the impact can be seen even 2 generations down the lane also. Now when we look at Indian data on the prevalence of childhood obesity, this is IGMR paper, again published, not recent paper, almost 8 to 9 years back, which showed that 1 in 5 kids in India are obese. That's a pretty huge number, and 9 years down the lane, maybe it's even worse as of today, because if you see the graphs are going up. There is no sign of plateau also. That's the even dangerous part with regards to childhood obesity as compared to maybe diabetes or adult diabetes. So I'm sure now it may be even more. Talking of Delhi, the CAR study published from AIMS showed that in Delhi, the prevalence of pre-diabetes is 50%. And the prevalence of type 2 diabetes is around 25 to 30%. The CAR study analyzed population-based data of Delhi, Chennai and Karachi. And so it's really, the most people don't even know it. The numbers are staggering and unbelievable. So I think we are also seeing more and more kids with type 2 diabetes, especially after the COVID pandemic, when sedentary lifestyle became so much more common, and the mobile phones and gadgets and technologies. Something which we never read in our medical school, kids in their end of first decade or early second decade of life coming with type 2 diabetes, frank acanthosis, skin tags, and it's really a sad story. So when we talk of diagnostic criteria, we cannot typically use the BMI cutoffs which we use for defining obesity and overweight in South Asians or adults. We have to use percentiles. I think we have to use weight, height and weight charts, and even easy to use is a BMI charts, I think. We have to realize anybody above 85th percentile is obese, anybody above 95th, overweight, sorry, 95th percentile is obese. And they have got severe obesity. When the BMI is more than 120th percentile for that age, we call it class 2 or severe obesity. And if the BMI is more than 140th percentile for that age, we call it class 3 or very severe obesity. The equivalent figures for adults would be like a BMI more than 40 or BMI more than 30 kilograms per meter square respectively. Again, when we look at a child with obesity, we always have to keep in mind syndromic obesity, which are a small number, but it's important to keep in mind. So as a rule, an obese child, an exogenous obese child would be tall. So the parents are happy, my kid is tall, he's doing well, a sign of affluence, good health. But these kids have puberty earlier, nearly 2 to 3 years earlier. So the epiphysis will fuse earlier and their final height will be compromised as compared to the peers who were of normal weight. So nothing to be happy of. Usually the obese kids are the tallest in the class, nothing to be happy of because their final height will be totally less or compromised. But if you come across an obese short child, that's a big red flag for syndromic obesity. So you should rule out hypothyroidism, you should rule out Cushing syndrome, and you should even think of syndromic obesities. There are other physical cues, the phenotype of the patient, the history of the patient, the vision, those histories, all the syndromic cause we should be taking. So as a simple rule is, a tall obese child, most likely we are dealing with exogenous obesity. A short obese child, very high likelihood of syndromic or endocrine cause of obesity in them. So as I said, it runs in families. You have to treat the whole family. You have to change the kitchen habits of the house. It's just not possible to teach the kids. Kids are smarter. You can advise them, but if you don't practice it, the kids are not going to follow it. So I'm not going to details of the features of different syndromic obesity. There's a beautiful article in JCM I would like to highlight, published in 2017, how it helps us in evaluating the different causes. What are the histories we should take? History of neurosurgery, history of hypothalamic tumors, small history there. Head injury can be a very important point we should keep in mind while history and examination of a patient with pediatric obesity. Now, why is it important to manage childhood obesity? Because we know the end organ damage of childhood obesity. There's a high risk of diabetes, hypertension, dyslipidemia, metabolic dysfunction, associated fatty liver disease. The key point is the data shows that the burden of end organ damage and the progression of end organ damage is much more aggressive and faster in childhood obesity as compared to the burden or progression seen with adult obesity. So yes, all of these complications do occur and they progress faster in untreated childhood obesity, and they are going to have a shorter lifespan and a more morbid lifespan, and it's really a sad story for the entire family, not only for the child. So yes, the cutoffs are also slightly different when we define that. That is important, especially when we look at dyslipidemia in children. The prevalence of MASLD is pretty high. Just that because we are not looking for it, we should have a low threshold for screening for MASLD in children with obesity. So sleep apnea is also increasingly being reported, and all of these are reversible with good amount of weight loss. So I think the treatment should happen as a whole of the family and society at large. I'm not going to details of diet and lifestyle changes. We all know that is important. But yes, when we look of childhood obesity, a few lines on obesity at an extreme young age of less than 2 years of age, it is uncommon. Only if there is a lack of breastfeeding, too much of top feeding, use of refined carbs, we are seeing it. So it is uncommon. And in this age, if you see severe obesity, you should again start looking for syndromic or any secondary endocrine causes for obesity. So the management is pretty similar. You preach what you practice, that is the way forward the entire family, otherwise it would be impossible to manage childhood obesity. With the use of food apps, online ordering of food, ordering food 24/7 has really made the worst in urban areas with regards to managing childhood obesity. I think indication of medical treatment is very clear. We would love all our kids to have their BMI down to less than 85th percentile. And if you look at medication, which was the topic for today's presentation, we don't have much of an options. Orlistat has been there, approved for use for a pretty long time now, but we know it is not a great, very potent anti-obesity agent. It has its share of mild side effects like flatulence, steatorrhea, but it has the best safety profile of all the available agents. Metformin we are using routinely in childhood obesity, specifically in pubertal girls with polycystic ovary syndrome. It really helps in taking care of different metabolic aspects, but we all know it's a mild weight loss agent. It's not a great weight loss agent. Phentermine not available in a country for use. It has been used in USA for up till 3 months of use is allowed. When you combine phentermine with topiramate, the quantum of weight loss is much more. Again approved for use only for short periods of time, not more than 3 months of use. Now what about GLP-1 receptor agonist, which is everywhere we see in social media, from medical literature to conferences? What about the use in children? This is a paper on use of liraglutide, with the high dose liraglutide. If you use in children above 12 years of age, they found that yes, there was around 5% reduction in BMI. So 5% reduction in BMI, not weight. That's a pretty impressive figure. But that's the high dose 3 milligram liraglutide done in primarily Caucasian population. We don't have Indian data, so perhaps we need to generate our own data, and my gut feeling is that perhaps we Indians have a smaller body habitus. We might do better even with lower doses of liraglutide. So this study led to the approval of use of liraglutide in obesity in adolescents more than 12 years of age. What about semaglutide, the more potent once-a-week injectable GLP-1 receptor agonist? There is no data on oral semaglutide. This is an injectable semaglutide. If you see here, the numbers are pretty staggering. Here we are talking of 16% reduction in BMI. That's again BMI, and nearly 73, virtually 7 out of 10 kids could achieve more than 5% body weight loss. So I think what the key point to remember is that the pharmacotherapy is not the gold mine. It is not the ultimate solution. These are short-term gaps for a better implementation of diet and lifestyle changes. So at least the child and the parents see some positive change, so they are further motivated to continue the diet and lifestyle change for a long period of time. If you are just on pharmacotherapy, sooner or later you are going to come back to square one. Because we are seeing with bariatric surgery also people losing weight, coming back, even overshooting even 5 years down the lane. That's not uncommon with bariatric surgery in adults. What about metformin we discussed, and of course for syndromic obesity we have specific drugs. We know the benefits of growth hormone in Prader-Willi syndrome. The setmelanotide specific agent works great in MC4R receptor mutations. What about bariatric surgery? Yes, there is data. Typically use is delayed unless the puberty is completed. The concerns with is the quantum of weight loss may have impact on the final height outcomes, the bone health outcomes in these kids. When we talk of bariatric surgery, primarily the malabsorptive procedures have been studied in adolescents and young adults, not the restrictive procedures, because the long-term side effects are much more with restrictive. Sorry, I'm saying the opposite. Primarily restrictive procedures have been tried and not the malabsorptive procedures, because malabsorptive procedures like RYGB surgery would have more potent weight loss and more longer metabolic effects. So sleeve gastrectomy is primarily which has been studied in children. So we published a systematic review on the outcomes of this metabolic surgeries, which is sleeve gastrectomy primarily in adolescents with severe obesity. These kids all of them had BMI more than 35 or 40 kilogram per meter square. Here if you see an average, the mean reduction of body weight was only around 25 kilos in these kids, and the percentage reduction of BMI was around minus 24% reduction in BMI. And of course, with such greater amount of weight loss, you have an improvement virtually all the aspects of the comorbidities or end organ damage like fatty liver disease, dyslipidemia, dysglycemia, menstrual irregularities, PCOS, you get a benefit. So yes, the data, follow-up data is available only till 2 years. What about the long-term effects? We still don't know. These kids are being followed up. Again, if you can't sustain a good diet and lifestyle change, you are going to come back to square one. I would like to end my presentation by saying that childhood obesity is a really, really dangerous medical condition, and its impact would be even apparent 20, 30, 40 years down the lane, perhaps even for the next few generations also. Not to be ignored. Treat the family as a whole. Unless the parents start losing weight, the kids are not going to lose weight. We should be role models for our kids and our neighbors and family members. Thank you so much.